So let's go ahead and get started.
So thank you for everybody to make the time, carve the time to maybe make this a little bit more of a great, successful event. What I would probably ask is if you have any questions, if there is a question and answer box that you will see, just go ahead and type it out and we'll start getting to them. Whether it be related to pain, sleep, and or billing related services, feel free to use that box. While we're getting questions in, I'm just going to pull up a few questions that were actually asked when people were registering, and at least get this going in regards to it. One of the questions from one of the, attendees was, how early can we diagnose sleep apnea in children, and what should be the line of management? So in regards to children, specifically, there's really no age restriction. I've seen kids get studied as young as 1 year of age. If you suspect that they have a problem, a test is going to be conducted. The only issue becomes is treatment options. Ideally, if we were to use an example of a 6 to 10-year-old, if we identify that the child has apnea by having a test performed by a physician, the choices would be first to have an ENT consultation to possibly evaluate the level of tonsils and adenoids. And if that's still a factor as far as impeding airflow, then the first line of treatment in kids will probably be tonsils and adenoidectomies. But the other thing that can also be just as beneficial with a TNA is maxillary expansion. Because what you'll find is there's got to be some etiological reason for a constricted airway aside from tonsillar growth. The other thing can also be a very constricted maxilla. And as a result of it, expanding the maxilla does have some significant benefits in these children. So hopefully that answers the question about how young one can be diagnosed, as well as what can be done as far as management is for these children.
And Mayoor, if I could just pop in for a minute, talking about child airway, Courtney and I have recently seen some policies that are actually starting to open up to pay for the expansion.
Oh, nice.
Yeah, and medically necessary orthodontics. And it's really, someone asked how you fill out a medical claim form, and that's a pretty broad question. But I think the question was, what's going to make the biggest difference? And there are diagnosis codes, not only, as you know, for TMD, TMJ disorder and sleep, but there are diagnosis codes for constricted maxilla and mandible. And so that's your starting point is, figure out, as Dr. Patel goes on, he'll say about, the diagnosis. And then that's going to relate to a diagnosis code, and that's your best starting point.
Got it. So that's good to know, actually, the fact that there's a trend towards at least managing these children and hopefully preventing further issues from that.
Yes, so it's exciting. It's good news.
Another question we had was, what would you like, would like to know a little bit about protocols on new TMD patients presenting to your office on a workflow, etc. Basically, how you go about starting this. I'll be frank with you, being that the vast majority of you have a busy general dentistry practice, trying to incorporate, whether it be pain or sleep, however we want to interpret this, can be a little bit of a challenge. What we recommend, and there again, it's entirely up to how your office flow is, but when you have these pain and sleep patients, you do not want to be disrupted. You want to basically give them your undivided attention. But to make that happen, you've got hygiene that you got to keep an eye on. You may have procedures that you may be having to provide. So it's always wise to possibly carve out half an afternoon or a half an afternoon where you start booking in these patients for both pain and sleep. And that's the only thing you do within a time slot. As time progresses and those time slots get occupied, then it's a matter of you deciding whether you repeat that on other days or you start extending it with one half day. The only thing you do is pain and sleep, and then compound that over time and open up more and more days. It gets very troubling and also difficult to have to take a history on a pain patient as an example, then get pulled away to go get a hygiene check done or deal with any administrative issues that may come up in the office. So I think the smartest way to do it, to make it work for you, is to literally just start carving time away for this to play out.
Great advice.
So I have a question in regards to using technology to validate positioning of an oral appliance. And there's many things on the market that one can utilize. You can use acoustics to measure the amount of volume space that one may have. Everything has a time and place. What ultimately happens is if you want to visually see that there is a change taking place in the airway by moving the mandible, then acoustic technology makes total sense. You can use radio waves to kind of get a sense of what baseline airway looks like. Once you position the mandible with some height and maybe a little bit of anterior positioning, you can retest that airway and kind of get a sense of what does it look like from its reflection of having nothing in the mouth. So they are technologies. It boils down to really what is most comfortable in your hands. Other methods one can utilize would be like a George gauge. Prometrics has one. Pro gauge is another. And so therefore, I wouldn't say one is any better than the other. It's just a matter of what works best in your hands to get your bite. Let's see. Rose, there's one here that says how best to fill out a medical form.
Well, how best to fill out a medical form. As I had mentioned earlier, you're going to start with having a diagnosis that's medically necessary. And the way that comes about is to utilize the treatment-specific questionnaire and exam forms. I think most of you know that Nierman Practice Management has developed questionnaires and matching exam forms, corresponding exams for dental sleep medicine, for TMD, implants, oral surgery, and we have an orthodontic module as well. And so if you start with asking the patient to fill out that treatment-specific questionnaire, now you're getting the symptoms that could or could not be medically necessary. Once you have those symptoms and you go on to the exam and you make your diagnosis, those are the things that are going to go into choosing your diagnosis code. So let's say patients came in with headaches and facial pain. When you do your exam, you notice there is an articular disc disorder of the right temporomandibular joint. And so what you're going to do is use an ICD-10 code for each of those. You're going to show, okay, patient has a TMJ disc disorder as your diagnosis code 1, and then your supplemental code will show the head pain or myalgia, and now you've got medical necessity just by putting the 3 diagnosis codes on there. So whether it's TMD or dental sleep medicine or medically necessary ortho, you want to start with those questionnaires and exams, and that'll guide you through the whole process.
Yes, and I mean, to be frank with you, when we started getting into this field, the best way to do it was to take a billing course and really get to understand the nuts and bolts associated with not just claims, but also the letters and coding, which is just as important. The good thing is, with our profession, there's just a number of codes that we need to be familiar with, as well as procedure codes. So this is definitely something that one can learn by just investing some time in being able to do so.
Absolutely.
And actually, a nice segue, speaking of billing, into another question that was submitted during registration. I think this will be for you, Rose. Was hoping to get your input on becoming a DME supplier for Medicare for sleep apnea devices.
Okay, well, that is, in order to be able to bill Medicare for sleep apnea appliances, one does need to become a DME supplier. There is a form, it's about 40-page application, and it takes at least 3 months to become a DME supplier. Once you get all the paperwork in and all the documentation, once you become a DME supplier, then you can start placing and billing Medicare for the sleep appliances. So that just, it's really important to have your ducks in a row and have the right documentation. And one good resource is to read Medicare guidelines for oral appliances for OSA. Then we also do have a service to help you become a DME supplier. We have a person in our office, Michelle, who's just dedicated to helping practices do that. So if you have any questions, please feel free to contact us too.
I have a question that I may need more information from that was requested as from one of the attendees. I'll read out the little that I have, and I think if you can just chime in by chatting in the other missing blanks, it would help. The question is about a patient that had a dream tap made who had a documented TMD disorder as well as Ellen's Down syndrome. She was told by a prior dentist that there was a disc that was missing on one side. So the assumption of making there is a disc that slipped on one side. But I would like to also know is how was that diagnosis made? Was it based with imaging or history to get a true understanding of what's going on with that one joint? She also suffers from migraines, and the appliance that was chosen for her was a tap-type device, since it would mimic the functions of an NTI type of an appliance. But she still has symptoms as a result of wearing this device. So my question, first of all, would be the initial diagnosis prior to fitting of the appliance. What was it that she had, and how was the confirmation about that one side determined? Knowing what she's presented with may give us a little bit more information to decide as far as not just appliance choice, but if the jaw needs to be addressed first prior to advancing the mandible forward. So for those of you, for that doctor that actually asked that question, there's just a few little pieces of information that would still be necessary to get a better understanding of what might be happening on that patient. There's another question about headaches in the occipital area. Where do they refer from? So occipital headaches can come from the trapezius. They refer them directly to the back of your head. It is the sternocleidomastoids and the front anterior aspect of the neck that can also refer to the occipital area. But another interesting thing that causes occipital type headaches is the greater or less occipital nerve. If it's entrapped or if it's inflamed due to some form of trauma or even negative posture, those in itself can give you an occipital type of a headache that needs to then be managed and addressed.
And Dr. Patel, real quickly, I see that the attendee that submitted the previous question did provide a little more info here. It says, I'm not sure, don't know how the prior dentist diagnosed her problem. She actually came in with several different orthotics from several dentists.
Oh, I see. Okay. So we have so we don't know what happened exactly for them to come up with that treatment plan, or the diagnosis at least. Which is fine. I mean, if we have more information, great. If not, not a problem. But it would help to just get a little bit more background on that individual so we can at least guide or at least suggest what you may be wanting to look out for to help her. I'm making the assumption, but I think it's a her. Yes, it was her. This question, what is the management of oral entrant communication and TMJ pain with crackling sound? You know, there again, I just need a little bit more information where exactly this oral antral communication might be. Is it within the jaw itself or is it elsewhere? Crackling sound, or we may describe as a grating sound, may be synonymous with what might be an arthritic change that has taken place in the jaw joint. So imaging would be important to see if there's any arthritis in the condyles of the temporomandibular joints. But in general, any sort of a communication that may exist, typically the only way to manage it would be to surgically close those openings to address those complaints. I hope that answers that question that was actually asked. What is the examination for difference to differentiate between muscle and joint pain? I suppose the most easiest way to define muscle versus joint is to just palpate the structures in question. So if examples with muscles, when you're palpating it, you want to apply approximately 2 pounds of finger pressure. I would always encourage you to calibrate yourself so you get a feel for what 2 pounds of pressure feels like. Push on the muscles of question. So in other words, if we were to push on the masseter muscle to pain, then that would be definitely a muscular component or myalgia as from a diagnostic standpoint. And if we go up to the lateral pole of the temporomandibular joint and palpate that structure by applying half the strength, instead of 2 pounds, 1 pound of pressure, if pain is elicited, then we will definitely call that joint pain, and a technical term for diagnostic purposes can be capsulitis that can be utilized. Rose, any other suggestions from a diagnostic standpoint as far as myalgia and or capsulitis?
Well, I'd just like to pop in and let everyone know that there were 2 new codes that came out at the end of last year for myalgia. One of them is myalgia of the muscles of mastication, and the second one is myalgia of the auxiliary muscles of the head and neck. And so it's exciting that they've actually, the ICD-10 has added new diagnosis codes for masticatory muscles. So we do have those codes available for you. So you can use those on your claims now. Say a patient comes in and has a TMD disorder, but muscle pain with it. You're always going to code your TMJ joint disorder first on your claim form, and then your secondary code would be the myalgia codes. Now let's say your patient came in and just has myalgia as the primary condition. You can certainly use those myalgia codes for muscle type treatments. If you're doing trigger points, that would be a good opportunity to use those as your primary code. But if you're placing orthotic, you always want to have one of your TMJ disorder codes as your primary and then put the myalgia as secondary. I hope that was helpful. That's a lot.
No, that helps. That helps. Actually, a follow-up to that would be this as well. A question that would be, can you bill for treatment for TMD issues with sleep patients in follow-up treatment?
The question is, can you bill for follow-ups for sleep and TMD?
So the question, I guess, is can you bill for treatment? So you have someone probably in a sleep appliance and a TMD issue arises. Can you bill for the TMD issues?
Yes, you can.
Okay.
Yeah. You wouldn't mix the TMJ and the sleep diagnosis on one claim. It would just be a TMJ claim.
Gotcha.
Yep.
Rose, here's another one for you. Is it possible to get the CT scan taken in an oral surgery office covered by Medicare?
Typically, Medicare's not paying for the CT scans, with one exception. If the patient has jaw cancer, some sort of major bone condition, then we'll see that CT scan being paid. Another area I've seen it is the diagnosis of infection of jawbone or a major cyst in the jawbone is the other secondary diagnosis I've seen a CT scan paid by Medicare. I typically don't see, I don't know if you've seen this, Courtney, I don't see the CT scan being paid for sleep or TMD diagnosis by Medicare.
I don't see that either. Looking at the surgical cases, as you mentioned, for that, and also a big heads up for anybody looking to go down that route is that, Medicare does consider that an advanced imaging, so you'll want to look into the accreditation programs in order for them to process claims for x-rays of that nature.
Okay.
Absolutely, that's a good point.
So then,
and speaking of Medicare, we do have another question in here about becoming a DME supplier. I'll squeeze in here real quick. Rose, do you know approximately how much it costs to become a DME provider?
I think that just went up, say, last week. I believe it's now $589.
Yes, ma'am.
Okay, good. Just changed like yesterday for the application fee for Medicare. If you have us do your DME service for you, we have an additional add-on fee to that as well, but it's $589 application fee.
Our service is $12.85.
$12.85. Okay, thank you.
we have a question here. General dentists able to become in-network providers?
You know, we do see quite a few of the practices we work with for sleep and TMD have become in-network, and it's becoming more and more common. I would start by contacting the individual insurance companies in your area, such as Blue Cross Blue Shield of your state, and the top 5 insurances, Cigna, Aetna, United Healthcare. But also go to this site. It's D.ABCP.org. And that's the credentialing website that insurance companies look at as a one-stop place to help credential you to become in-network. There you go, CAQH.org. So that would be your starting point.
Nice.
And Dr. Patel, a question here for you. If a patient presents with some form of TMD, for example, early clicking, that's gone untreated and also shows signs of sleep apnea, such as tori, occlusal wear, etc., should you first treat the TMD? What's the ideal protocol for someone who has chronic TMD?
That's a good question. So we'll go to the first one. If it's just early clicking and the patient doesn't present with any signs or symptoms, and yet they need to be managed for their sleep apnea, then typically I would proceed with managing their sleep apnea. But the note of caution that the patient will be advised is the idea of what the clicking joint is. And what you need to basically educate them is a clicking joint suggests that your disc is out of place. And when you wear such a sleep appliance, there's always a good chance that it may go back in place, which means the clicking will disappear. But if the clicking does disappear and the tissue does go back into place, then the side that the joint was clicking, there's also a slim chance the teeth on that same side may not completely touch the next morning as a result of the disc being reduced. So besides that note of caution, there's really no reason why you shouldn't. If we take that question one step further and said the person has a clicking joint and has pain associated with that, then you do want to definitely manage the jaw issue first prior to advancing the sleep appliance, because worst case scenario, you may make the jaw condition worse where the patient will be non-compliant then to the oral appliance. So I hope that answers it, but it will probably be based on what symptoms exactly the patient's presenting with to give you that guidance.
Great, thank you, Dr. Patel. Rose, this one will be for you. Since Alabama has no state mandate for TMD coverage, what would be your advice to get paid by medical to help patients accept more treatment? Or will this be a situation where we will be mostly a cash practice?
Well, that's a great question. I don't know if everyone on the line is aware of this, but there are, I think, about 40 states that at least that have mandates that TMD has to be covered under medical insurance. And one of the states that doesn't have it yet is Alabama. And it doesn't mean that the policies won't pay for it. It just means that the state has not mandated that. So what I would do is take each case and verify, do a benefit verification for each insurance when the patient comes in. We're going to do that where you have the state mandate or not. That's always your first step. Pick up the phone, give them the diagnosis codes, and ask if it's covered or not. So that's your best bet. And then you can find out immediately if not necessarily if they're going to pay or what the fee is, but if it's a benefit as part of the policy or not. That said, your best bet is once you know that, of course, work on a payment plan as always with the patient.
Great, thank you, Rose. Dr. Patel, back over to you. Follow up from the last question. How long them for the TMD before OSA?
Yeah, most TMD symptoms have a tendency of resolving themselves once active treatment is rendered between 1 through 4 months. So the idea here is to manage the individual until they are symptom-free. This can happen in as short as 4 to 6 weeks or may take up to about 12 weeks or so. But once that jaw demonstrates complete resolution, then go ahead and proceed with managing the obstructive sleep apnea aspect.
Great, thank you, Dr. Patel. Rose, back over to you. What code should we be billing for TMD with OAT?
If you're billing for TMD, the diagnosis of TMD with oral appliance therapy, is that the question?
Yeah, I believe it's all TMD related, but
okay.
Christopher, if you could clarify for us when you get a moment, if you're looking for answer on TMD and sleep, or just the appliance therapy for TMJ disorder?
Yeah, I think I understand the question. We were talking earlier about diagnosis codes and which diagnosis codes to use. You use a TMD one and a symptom one. This is probably asking what codes you use for the actual TMD appliance. And there's two that, depending on the insurance, that are accepted. Some insurance companies would like to see the dental code on a medical claim, the D7880 for occlusal orthotic device. But I think it's about half and half. The other, maybe more of them, I'd say about 50-50. The other insurances are looking for typically the 21299, which is a medical code for unspecified cranial mandibular procedure with narrative report. Now, each of these codes will need a narrative. And so when I do that insurance benefit call, I'm going to give them the diagnosis codes, and then I'll say, okay, which of these two codes do you accept? And it typically will be one or the other with your narrative.
Okay, great. Thank you, Rose. Dr. Patel, back over to you. Where do headaches at occipital area, it says refer from, but where do headaches at occipital area refer from?
So basically you're looking at traps, you're looking at the sternocleidomastoid muscles, and also if the greater or lesser occipital nerves are either entrapped, whether it be entrapped within muscles or have been injured because of blunt force trauma, will be the most common reasons to have occipital type headaches.
Great, thank you. Another one for you, Dr. Patel. A patient awakens with aching on one side by zygoma anterior to joint. After wearing bilaterally adjustable MRD without pain during sleep all night, discomfort subsides over a few hours. I think more of a little bit of a comment, but your thoughts on that situation?
So just to extrapolate that again, so it seems like when they wear the device, they do good, but when they take the device out, they have symptoms in the zygoma area. Is that how it's written?
Right. While they're wearing the appliance, sleeping without pain, but awakening with aching on one side by zygoma anterior joint insert.
So there's probably two reasons, maybe three reasons for this. The first one that comes to mind is if you're wearing the device and you feel comfortable, but when you remove it, is it possible that the lateral pterygoid muscle on that side is involved as a result of the device being held forward, but the next morning, as a response to it not being held forward and allowing the mandible to protrude posteriorly, it can be where it may act up. First thing would be to test if it's lateral pterygoid muscle by at least provocating that muscle. And if it is, then addressing treatment in relation to it. The second common area would be, because it's a zygomatic arch, will be the masseter muscle itself. It can be that it's a muscle that has myalgia or some form of a myospasm that may be a reason for that pain. Very rare to see that type of a configuration, but still something to keep in the back of your mind. And last but not least, if it's zygomatic pain, I would look at the joint as well. If there's anything happening with the joint that can explain those symptoms. And if that's true, then addressing those areas should resolve the problem the following morning.
Wonderful. Thank you, Dr. Patel. I've got the next one ready for you. If a TMD patient is treated with myalgia and becomes symptom-free after 3 to 4 weeks of nighttime wear only, would you then recommend to attempt to wean the patient off the appliance and use as needed, or tell the patient to keep using every night?
So good question. I guess the bottom line would be is why did they have pain in the first place? If the pain was due to nighttime behavior, more commonly parafunctional type behavior, then I would encourage them to continuously wear the device. On the other hand, if it was an acute onset where they had no pain before, they develop this pain, you address the pain within 3 to 4 weeks, then yes, I would probably make the attempt to not wear the device and see if the symptoms return. If the symptoms do return, then the solution is to be basically married to the orthotics. On the other hand, if the symptoms are resolved, then there's no need to do any further treatment to that individual.
Great, thank you, Dr. Patel. Rose, billing question for you. I've heard a lot of different suggestions on what our fee for sleep appliance therapy should be. Do we have any idea of what insurers tend to allow for sleep appliances?
Well, that's a really great question. And we did a survey of the medical billing claims that were filed electronically through Nierman Practice Management last year. And I think in January through June, the average fee that insurance companies pay for the sleep appliance, not the whole case, just the device, was $3,200. We did another survey, pulled out some data at the end of the year, and I think it was a little closer to $3,100. But right around those ranges is you're going to see less and you're going to see more, depending on the carrier and the plan. But that's what came back as the average. So, you just definitely want to make sure that your fee is, above the usual and customary to some degree.
Great, thank you. Dr. Patel, another one for you here. What are your thoughts on Spear's Seattle protocol for treating airway? Mainly, first start by screening patients' airway, have them use mouth tape / nasal passage opener for 14 days therapy to decide which route to go, i.e. refer out to ENT or intervene with some form of therapy.
I've not heard a Spear's Seattle protocol, but if we just dissect the questions that were asked, first step would be to screen patients for airway, which is so true in any aspect. Mouth taping, nasal passage opener. The only time really mouth taping a nasal passage may be indicated if there's a nasal issue where the person has a tendency of being a mouth breather, then taping would definitely be recommended. We do know that it helps better oxygenation for you to breathe through your nose. It also helps you to increase your parasympathetic activity by nasal breathing. But does it really make a significant difference in apneic events if one were to have it? Not too sure. There's very little literature to support that taping the mouth would have a bearing or a positive bearing on airway itself from an obstructive standpoint. So, I can see the rationale for why they may want to consider taping to see how nasal passages function for about 14 days. And then make the appropriate recommendations. I guess we should also remember that dentistry is not, medicine itself is not a cookbook. We can't do the same thing to everybody and expect the same results. We all have to, based on what our clinical findings suggest and also what the key diagnosis might be, and tailor our needs based on it. So I would refrain from using a cookbook approach, but more importantly, I would suggest that you just get a better understanding of what the individual has by either running tests, asking the right questions, or imaging when required, and then target appropriate treatment to rectify or to correct what you may suspect before proceeding any further. I know it's pretty loaded as far as the question was, but it's not. There's no one simple way to actually answer that. But hopefully you get a sense that go with what you think the patient has by your examination before you just do the same thing on everybody and expect different results.
Great, thank you, Dr. Patel. Rose, question for you. I've heard that Medicare won't cover a sleep appliance if the patient has tried Cpap. Is this true?
Well, that is something that has come about in the last few months, maybe the last 9 months. Medicare started enforcing something called the same and similar rule. So if the patient is still using the Cpap, or they're not sure if they turned it in or still using supplies, then yes, in their opinion, an oral appliance would not be medically necessary. So you do want to be very careful to check with your patient. who has worn CPAP, or find out if they have, and make sure that they have not, that they've turned it in, just to be on the safe side. In that case, you might have this, I would recommend you have the patient sign an ABN, an advanced beneficiary notice, just notifying them that because of that, Medicare may not pay. It's an ABN.
Now, what if they did turn in their CPAP?
Then if they did, what you're going to do is send in a redetermination, which is an appeal. And there's a specific form to do that appeal on, the redetermination.
Yes, and I know the next question will be, do they work? And yes, absolutely, as long as the patient does meet Medicare's criteria for coverage. We have seen plenty of redetermination requests be submitted and basically the denial overturned and paid. All right, Dr. Patel, back over to you. Does the dentist/oral surgeon get involved with providing CPAP machines, or is that left to pulmonologists and dentists to stick to appliances and associated treatments?
Yes, that's so true. We are not allowed to dispense CPAP machines. Typically, it's dispensed by a sleep physician, but typically it'll either be a respiratory therapist or a sleep technologist that has training for CPAP machines and so forth. So we as dentists basically stick to oral appliances with an order from a physician to provide that service to the patient. And CPAP is typically left in the medical realm as far as being provided and managing.
Great, thank you, Dr. Patel. And actually, we have a nice comment here in the chat box as a follow-up from the Medicare same and similar that Rose just touched on, that if the patient has used the CPAP for more than 90 days, Medicare won't pay for 5 years without assigned ABN. So thank you for that comment there. Just to clarify the ABN thing with same and similar, as Rose mentioned, you do want to go ahead and have that ABN signed by the patient, whether the patient flat out tells you that they have had a Medicare pay for a CPAP within the last 5 years, or if you can actually check that through Medicare's system, through the IVR, which is the automated phone system, or if you do have a login through the website, through the DME portal, you can also check it through there. Now, it is true that you can fully expect a denial on your first submission, which with the ABN will cover you to be able to charge the patient if ultimately it's not paid. But the great news is once you receive that denial, as long as the patient has returned the CPAP and meets all other criteria, you do have a good chance of having Medicare overturn that redetermination and pay for the sleep appliance. But there are very specific things that Medicare expects to see included in that redetermination request, such as the sleep study within 12 months of the delivery date of the appliance, and notes from the treating physician as well. All right, next question here for Dr. Patel. Can we still treat patients effectively without tomo imaging? If we have a CT machine in office and can complete all necessary palpation evaluation / questionnaire, is this sufficient?
So I'll go with the notion that with the CT machine, if you do have that, then you should be able to extrapolate tomography views from it. But if we were to answer this question in another way, yes, an evaluation, palpation, a questionnaire, and provocation of the jaw, muscles, etc., with even a panoramic may be sufficient for you to treat these patients. The only problem with the panoramic is very difficult to really look for arthritis in its early stages. The only way to really see that is with tomography. But above and beyond that, if you look at the standards from the oral maxillofacial surgeons' practice parameters, the recommendation for imaging of the temporomandibular joint is actually a panorex. So yes, from that standpoint, you could do it. But if you do have a CT machine, then you should be able to extrapolate tomography views from that machine itself.
Okay, I think Courtney got hit by that storm. So I'll take over with the next question. This one will be for Dr. Patel. Let's keep going with you. As a general dentist just starting to treat TMD and sleep, what would be the best advice you have to market yourself? Would you target more patients or target NPs, PAs, MDs to build internal referrals?
I mean, the best thing is to go direct to your physicians and the auxiliaries, which are nurse practitioners and PAs. What you'll find is when a physician or an NPPA suggests to a patient that they need to do a follow-up or a consultation with you, they're more likely to come and they're more likely to render treatment or at least go with treatment. When you go direct to consumer, with sleep, it may have a little more benefit than with pain. But when you target sleep patients, I would specifically target those that have already been diagnosed and are non-compliant to Cpap therapy. This way, you already know the diagnosis has been rendered. It's just a matter of now getting a referral from the physician, which you can also get after the fact, in the sense that if the patient comes in, you could always request for permission to proceed with an oral appliance, but you can wait to deliver the oral appliance until you get that signature on file. So, I mean, from that perspective, building a practice, best thing is to work with your medical peers, also your dental colleagues, letting them know what you do as far as services you're rendering, and then going to consumers next.
Great answer. All right, this next one is for Rose. Are the codes for the sleep appliance and the TMD appliance the same?
No, they're actually different. Whether it be the diagnosis codes, those are, of course, going to be unique. But the procedure codes are also different. As you can see on the screen, I think it's the 5th or 6th down, what code should we be billing for TMD? There's two choices there, depending on insurance preference. Now, for the sleep appliance, there's only one code. And John, we just typed it in there, E0486. And that's a custom appliance for sleep apnea, obstructive sleep apnea.
Great answer. And then the follow-up to that is the average reimbursement may be around $3,200 or so. Is it the same for TMD appliance?
Actually, we'll probably see less on the TMD appliance. And again, just keep in mind that for the sleep appliance, you're not always going to get the $3,100, $3,200. I mean, some are going to pay as low as $800. But I mean, that's really low. And some will pay more, but that's the average. I would say, for what I've seen, the average fee for TMD appliance is, if they tell you you have to use the D code, D7880, it's going to be anywhere from $600 to $1,200. If you can use the 21299 unspecified craniomandibular procedure, we're seeing higher amounts for that. Anywhere from, gosh, I've seen, up to $2,500 for that TMD appliance. So it varies quite a bit.
And one more insurance question while we're on the topic.
All right.
Does insurance pay for the morning repositioner?
There's not a code for that. So I do believe that I have seen some practices go for that, but I do believe that the insurance company does expect you to bundle that in.
So don't bill for that.
Yes.
All right. And let's see, another insurance question. Once diagnosed with sleep apnea, is the patient's future life insurance rates at jeopardy to rise? Does it become a pre-existing condition for new insurance coverage?
I think that would be have you seen that? That would be a good question for Mayoor. I know some patients are concerned that it's going to affect their life insurance and other areas of their life. Have you seen that with any of your patients?
So, I mean, I've heard people talk about it. I've had people say that if you can prove that you're being compliant with the device, for example, let's use Cpap, you can demonstrate the person's compliant. So therefore, it's almost like having diabetes with blood pressure. If you at least have it under control, it really won't make a significant dent in it. But I have had others that just do not want to get treatment done on the premises that it may affect their life insurance policies, especially if they're trying to get a new policy. If they've already gotten one, it's not a problem, but it's trying to write a new policy, then yeah, it may be in some circumstances, because they do take into consideration pre-existing conditions.
Okay, great answer. Another one for Dr. Patel. Dr. Patel, do you have a recall sequence for home sleep test time after final appliance position is determined?
So typically, we between 4 to 8 weeks, if everything goes well, subjective improvements have taken place from the time of delivery, then we'll have a test ordered for the patients to get done. There's one study that actually looked at reduction of edema in the oropharynx, and it turns out that it does take up to 3 months before you get significant reduction in edema as a result of snoring. So if we were to look at it from that perspective, then we may want to be waiting close to 3 months. But the same token, it would be nice to know whether the treatment that you've rendered is beneficial than to wait 3 months and determine that we need to advance or titrate or whatever the situation might be. I will share this, and this is all anecdotal at this point. We've seen situations where we test them at 4 weeks and they do nothing with the device. But later, 6 months or greater, the test is repeated and we see a significant reduction from the test that was priorly conducted with the device. So I believe by waiting for a period of time, you do get some improvement in the oropharynx in some cases.
Okay, great answer. All right, another question for Dr. Patel. A follow-up to the previous question about who to market to. Do you feel that in order for optimal success, that a dentist should go through an accreditation by, say, the AACP or equivalent? Or is a thorough background and CE in the areas of interest, is that sufficient?
If we were looking from the area of sleep, then I would suggest you go ahead and get yourself credentialed, only because physicians understand that to do sleep medicine, most of the physicians are boarded in sleep. So I think the same rules would apply when it comes to dental. They can appreciate and understand that you have reached a level of confidence in managing these patients. When it comes to pain, interesting enough, most physicians think that us dentists have been trained effectively in dental school to deal with temporomandibular joint disorders, which is why a lot of times they'll say, just go see and go back to your dentist and have your dentist deal with it. So I don't think credentialing is that much more necessary when it comes to pain. It might be more important to separate yourself from your peers as far as your level of confidence or your level of knowledge. But I would say that if you are targeting sleep, then yes, definitely do try and get credentialed.
Great answer. All right, and finally, do you recommend for patients to get restorative work completed after their OSA is stable with oral appliance therapy? Mainly for those of us GPs who plan on treating OSA patients, how do we manage the changes that may occur with their occlusion?
So, I mean, at the end of the day, one of the side effects associated with oral appliance therapy is a change in bite that may happen, and it typically only happens if the patients don't follow through the following morning. So as long as the patients understand what is expected of them when the device is removed, you don't typically see a change in occlusion. But at the same token in time, if restorative work is necessary, then I would probably lean more towards getting the restorative work done first, making sure the teeth are healthy prior to fitting an oral appliance. And the type of restorative work that I may be leaning towards is extensive work like crowns and things of that sort. Fillings can be done even with the device present, And if you happen to have to do a crown when they already had received a device, then just make as much effort as possible to try and duplicate the original size of the tooth they had and have the laboratory match the new prosthesis to that so that the sleep device does not have to be remade or significantly modified for you to fit that tooth in question.
All right, I think we have time for one or two more questions. And this one will stay with Dr. Patel. What percentage of the general population suffers from either sleep apnea or TMD?
So with sleep apnea, you're looking at about 28% men, 9% of females that have some sign or symptoms associated with obstructive sleep apnea. When we talk about TMD disorders, the numbers do vary, but the estimates run anywhere between 5 to 10% of the population have at least some sign and or symptom associated with the temporomandibular joint. What you also have to ask yourself is some of these papers that were done, what did they use as inclusion criteria for TMD symptom? If we were looking at just jaw popping, clicking, pain around the face, specifically the jaw muscles and so forth, that may bring up a small segment of the population. But if we start looking at some of the other common symptoms associated with the temporomandibular joint disorders, such as headaches, tension type headaches, in some cases migraine type headaches, of course also neck pain, then the numbers are probably much higher.
Great answer. And then a follow-up to that for Rose, how long does it typically take for insurance companies to reimburse offices for the billed treatments?
I'll jump in here. You know, the turnaround time for medical claims will vary on, you know, a few factors. Typically, if you submit a clean claim electronically, you know, you can expect reimbursement as early with some medical insurers as 2 weeks. But typically, you're looking more along the lines of 30 days or so. Of course, submitting paper claims does slow that process down. For example, Medicare puts a 28-day hold on claims submitted via paper. So, you know, if you make sure to submit your claims electronically, that will definitely speed up the process.
All right. And look at that. All of the questions have been answered. I think that's a first.
Awesome. This is fantastic.
Right on time, 8:59.
Awesome.
Perfect time. Look at that. So
what a great group.
Yes.
Great group.
Absolutely.
Great questions. Great questions.
Well, I want to thank everybody for joining us, and I hope you gained some valuable information. And thank you again, Dr. Patel and Rose, for sharing all of that knowledge with us. And before you guys go, I did want to just share with you guys our schedule coming up. So if you really want to dive in on these topics in cross-coding and medical billing, dental sleep medicine, airway, and TMD and craniofacial pain, we have some really great courses coming up with Dr. Patel and Rose and our other speakers. And here's our list here. And if you just go to niermanpm.com/schedule, you'll come to this page, you'll see our whole schedule, and we have some really great clinical courses coming up. Next weekend we'll be in New York for TMJ for the dental sleep medicine practice. This is a really awesome course. We have 4 speakers, Dr. Patel, Dr. Terry Bennett, Dr. Brajesh Chandwani, and Dr. Michael Gelb will be joining us. So that's going to be a really, really fun course. And then we'll also be in Seattle, DC, Long Beach, Chicago for our sleep implementation course. So we're hitting all those major cities. And then if you want to dive deep with sleep and pain, we're doing a brand new course called Critical Thinking and Problem Solving for Sleep and Pain with Dr. Patel in Atlanta, right in his office, October 11th and 12th. That's going to be a really, really cool course, a little more advanced and more of a grand round style. So we're really looking forward to that. And then our Dental Writer User Conference and Dental Sleep and Pain Conference, we're going to be in Fort Lauderdale at the end of the year. So you can come join us there in Fort Lauderdale for our annual user conference, and we'll have a lot of fun playing learning games and We'll have 2 different tracks. We'll have a clinical track and a dental writer and coding track. And next to those clinical courses, we usually have a cross-coding course. So if you see all these different cross-coding courses going on. And finally, we have our mini residencies that we're doing. We have our sleep mini residency and we have our pain mini residency. I know a lot of you are actually part of those mini residencies going on right now. And we're doing a whole nother class starting up in September for our sleep one and starting in November for our pain one. So we have plenty of opportunities. Plus, if you want to shadow Dr. Patel's sleep and pain practice, we have those opportunities as well. We can get you in on a Monday and Tuesday. That's available. And you get to see how his whole flow is with his practice as he treats his patients. You can bring your team members and they can shadow his team members, and you see how he's made it a well-oiled machine. So a lot of opportunities coming up. I hope to see you guys at a course. Hope you can make it to one of them coming up. And if not, we'll see you on a webinar. Just stay in touch with us. We have plenty of ways to stay in touch. Contact us at dentalwriter.com. You can go on our website, chat with us, give us a call. We are always available Monday through Friday. So if you have any other questions, just let us know, and we'll see you on the next webinar or at a course.
Well, thank you, everybody, so much for coming. And I'd also like to thank, of course, Dr. Patel again. It was just so helpful. And also John for hosting it, and Courtney for her wonderful medical billing knowledge as well. So thank you, everyone.
Thanks a lot, guys.
All right, everyone have a great evening.